All right. Good afternoon, everybody. Thank you so much for joining us today. My name is Monica Lindstrom, and I'm one of the board members for Arizona Foundation for Women. If you are looking for our She Talks, then you are in the right place. So we're looking at about an hour today full of some very interesting, helpful information. And I'm going to look at the title so that I don't say it incorrectly, because for me, it's a bit of a tongue twister. It's our innovative, new, and less invasive treatment options for breast cancer. And we know that, at least in the near future, breast cancer is not going away. And we've all known somebody, or will know somebody most likely, that has had breast cancer. And so this information, even if it hasn't directly affected you yet, could definitely affect your life in a positive way if someone you know or love ends up being diagnosed with breast cancer. So we are so grateful to our speakers today that are here, and I will be introducing them in just a minute, and we'll jump in with some questions and this incredible new technology, at least it's new to me, and information that is so incredibly important. Now, some things about Arizona Foundation for Women. Some of you that are listening and watching us today know all about AFW, what our mission is. You've volunteered or you've been part of our incredible group. Those of you, this might be brand new to you. So Arizona Foundation for Women, our mission is all about helping women in our community. It is advancing the status of Arizona's women through research, advocacy, and philanthropy. Now that is a mouthful, let me tell you, but it takes a lot of work, and we're really happy to do that. One thing that we say is we like to wrap to she, the research, advocacy, and philanthropy, to she, the safety, health, and economic empowerment of women here in Arizona. So everything we do, from our events to our She Talks to our She Leads program to our website, everything has to do with wrapping to she and helping the status, improving the status, both physically and mentally and economically, for women here in Arizona. So if you would like to be part of that, we have a lot of ways for you to be part of our group. You can volunteer, you can become a member. A member is where you give a monthly donation each month. You've probably seen many programs like that, and you get to help us with things and determine how the money that we raise goes to different grantees. And we value your insight and really bring you into our group and have you become an integral part of this incredible community that we live in here in Arizona. Another thing is our She Partners program. Now, this is a very exciting program. Maybe you have a company or an organization that focuses on women, or they're deciding that they really want to branch out and help women and focus on women. You can become one of our She Partners, which is when we collaborate with those corporations and organizations to really move the status of Arizona, or of women here in Arizona. So we have memberships, we have regular volunteer positions, and we have the She Partners, and that helps with our different programs. You might have heard me mention She Leads. That is one of our education programs to create leaders in Arizona. And you can find all that information on the website about that. That's a pretty incredible program. We also have our She Talks, which is exactly what we're here to do today. This is our opportunity to educate our community on different programs, different ideas, technology, skills out there that can help women, which in turn helps the children, helps the men, helps our older generation, because it is women that seem to be, the center of all of that. When you have strong women, you have a strong community, and that's so important, as we all know. All right, so let's see. I talked about our mission. We wrap to she. Our membership, and that's for as little as $10 a month, and we would love to have you as part of our group. The volunteers, the She Partners, and She Leads. I think that is a little bit of everything we do here. So go ahead and go to our website, azfw.org. You can get lots of information about all those programs and become involved today. So that would be wonderful. We'd love to have you. Okay. So I'd like to go ahead and introduce who we have here on the screen, but I first want to start with Scott Pierce, and I'm going to look over here so I get this information correct. He is the sponsor for this incredible She Talks today, and he is the owner, I believe, Mr. Pierce, of Ice Cure Medical Inc. U.S. commercial. He's the U.S. commercial director of Ice Cure Medical Inc. Mr. Pierce, tell us a little bit about Ice Cure and what the company does.
Yeah, I'd be happy to, Monica. Thanks. And I have some slides that I can show you to walk you through. Is that okay? Yeah.
Pictures are worth 1,000 words.
Yeah, we'll get started right on that. And as she indicated, I am the U.S. commercial director, not the owner, although I wish I were at this point. And my name is Scott Pierce. I live in Colorado, so not too far away from you guys. We connect with states. And the company is called Ice Cure Medical. And our product is called the ProSense Cryoablation System. And the company is actually based out of Israel. That's where the product was developed, and the research and development and the corporate headquarters are there. It was founded in 2006 with a main focus of treating cancerous and benign tumors. We use a technology called cryoablation, and specifically our product uses liquid nitrogen, which is a kind of a gaseous product that we use for cooling. It gets very, very cold. Our focus is in the women's health area, specifically in breast cancer, and also in interventional oncology. So there are other types of tumors, say kidney, liver, lung, that can be treated with cryoablation. And as I mentioned before, ProSense is our primary product, and I'll show you a picture of that in just a second. It's used in the office. It can be used in hospitals as well, but it's really, I know Dr. Barclay-White uses it right in her office. So real quick, a couple pictures. Cryoablation is just what it means. We freeze the tumor. The doctor will use ultrasound for guidance. We stick the needle in, a single needle stick. And you can see in the middle image, it's sort of a cutaway of showing the ice ball forming. And that's exactly what it is, which is an ice ball. And at the end of the procedure, it's a simple Band-Aid where the needle was placed. Now, this image has a lot of stuff going on about cryoablation and what's going on. But the takeaway is we use very, very cold temperatures to kill the tumor cells. And it's a whole process that goes through it. Direct damage, indirect damage, even some immunologic responses that could occur that people are studying right now with that. And if you'd like to learn more, there's a lot of information out there on it. Here's a picture of our system. So that's the console, and the little thermos container is where the liquid nitrogen goes. We fill that up, that goes inside the console. And then you can see the handle with the needle, and that needle is sterile. And the doctor would use that to place it within the tumor under ultrasound guidance. The procedures are always dependent on the tumor size, anywhere from 15 to 30, 35 minutes total freeze time. The prep is very fast, and really it's a very straightforward procedure. The pain is minimal. The doctors will use anesthetics directly located, so you're not under it, you're awake while this is happening. And the cooling actually acts as an analgesic. So it's, think of ice on a bruise where it's causing that effect. And then from the user standpoint, you can see it's a very simple touch screen. And we've had some, the results, which I'll show you in a minute, the cosmetics have been very positive. We have various cryoprobe sizes, so that's all dependent on the size of the tumor you're trying to treat. We really focus on safety and efficacy. That only that tip part gets the ice ball on it, so it's a very small localized area. And then the system, is very easy to store and environmentally friendly. Just a couple of bullets here. We are FDA cleared for many applications. We have a clearance for fibroadenomas, which are benign breast tumors, and some doctors will treat those, the benign fibroadenomas. We have several CE marks, so if anybody here is calling in from Europe, we have all the indications, and it's available over there. Something exciting for us, we were granted a breakthrough device designation in March from the FDA, and this will be to pursue the breast cancer indication, which we hope to have by the end of this year. And then we're also working on a registry, which will be in conjunction with the American Society of Breast Surgeons and some radiology societies to capture more clinical data. So the more clinical data we can get, the better. The latest study we did was called the ICE3, and Dr. Fine, who's based out of Memphis, presented some interim data at the American Society of Breast Surgery meeting last month. And it was we have 3-year results and some 5-year data. So the next slide will show you a quick overview of this study. It was a treatment for breast cancer. The lesions were not excised, so they froze the tumors, and then we followed the patients. And you can see there were 194 eligible patients over 19 hospitals in the US. 49 patients by the end of June will be followed for 5 years. So it's good 5-year follow-up. The data of the 194 patients, 190 of them did not have any recurrence. So that's a 97.94 recurrence-free percent. 100% of them were safe, so no adverse events. And then we, as I mentioned before, we had some patient and doctor satisfaction surveys done during the study, and you can see they were in the high 90%. And again, this data was presented by Dr. Fine last month at the ASBRS. So very exciting data that's coming out of this. And with that, I'll thank you for giving me the opportunity to speak to you today. It's really exciting technology. I'd have to say that the doctors, such as Dr. Barclay-White, are really the ones behind this. They are the experts in the field, the treatment of the breast cancer. I was privileged enough to observe some cases with her last month, and her team are just fantastic. So you're very lucky to have her in Arizona, and we're very happy to be working with her on that. So thanks again. I'll turn it back to you, Monica.
Thank you, Scott. That was Scott Pierce. He is the U.S. Commercial Director of IceCure Medical, Inc., and he would love to be the owner, wouldn't we all? But thank you so much for sponsoring today's She Talks. We really appreciate it, and it's very exciting what IceCure is doing. I'm very, very excited to be able to talk about this today. And before I introduce our two distinguished guests here, I also want to give a shout out to Pure Insurance and Rosendin. They are two of our She partners here at Arizona Foundation for Women, and we greatly appreciate all their support and help in helping us complete our mission, or at least since there really is no completion, continuing our mission to help women in Arizona. All right, so let's go ahead and get started with some wonderful questions. We have Dr. Belinda Barclay-White. Now, let me give you some information on this outstanding woman. She is a board-certified radiologist who specializes in breast imaging. She attended King's College, London University, and Westminster Medical School. You'll be able to tell with her little accent there, which I love, by the way. In 1976, she immigrated to Phoenix and completed a diagnostic radiology residency and fellowship right here at St. Joseph's Hospital. She's been living in and serving the Phoenix community for 40 years. So she truly loves Arizona and Phoenix. And this time she founded Arizona Breast Net. It is a full-service diagnostic breast center with the intention of making a mammogram a more pleasant experience. And yep, that's a tough one, doctor, but we appreciate you doing that. Women's wellness and health is not only her career, but it is also her heartfelt dedication. As a mother of 3 daughters and a proud grandparent, she believes the well-being of women directly impacts the well-being and safety of their children and families, which is so true. We definitely acknowledge that here at AFW. She's always exploring ways to improve the overall health of women through nutrition, exercise, and encouraging a healthy living. So thank you, Dr. Barclay-White, for being with us today. And the gentleman seated right next to her is Dr. Dan Rubin. He is a naturopathic doctor based in Scottsdale, Arizona. He has a naturopathic oncology practice that's been an integral part of Phoenix metropolitan medical community for the past 20 years. And I just want to say, I find it interesting how we have a naturopath and a medical doctor here together with the same interests, because I think a lot of people out there, they see that as kind of conflicting. One can't survive with the other, and just seeing the two of you here, that's obviously not true. And so I know that you'll explain that to us and how you can work together to get through this. He, after graduating from Southwest College of Naturopathic Medicine in 1997, he returned to get his residency. In 2004, he became the founding president of the Oncology Association of Naturopathic Physicians, otherwise known as, is it on AMP?
It's ONC-ANP.
Onc
For oncology and yeah.
ONC-ANP. I'm glad you said that. He represented a revolution for the field of naturopathic oncology, providing for the first time definition, validation, and standardization of the field of naturopathic oncology. Since that time, Dr. Rubin has become an internationally recognized naturopathic oncologist. Do you have an accent too?
Yeah, Chicago.
Oh, okay. All right. Dan is co-founder, along with his wife, Deb Smolinski, and medical doctor of Naturopathic Specialists, LLC in Scottsdale, where he practices full-time as a naturopathic oncologist. At present, Naturopathic Specialists has served the clinical and logistical oncology needs of people from all 50 states as well as 19 countries. So he is an expert at the integration of traditional and naturopathic medicine for people with cancer and services both adult and the pediatric population. He's also an expert in the naturopathic approach to people with cancer who are either unable to undergo conventional therapy or who choose not to. His selected positions include those from the regulatory, education, advisory, and community sectors, and his main philanthropic interests are focused on children with cancer as well as a postgraduate education. Dr. Dan, I can't imagine having to deal with children and cancer, and just the fact that you are willing to do that makes you a pretty incredible person. So thank you both for being with us here today to help us bring some awareness and have you drop some knowledge on all of us out here about these incredible advances that we have. So let me go ahead and start with you, Dr. White. How did you get into focusing on breast cancer as a radiologist?
Well, I was the only woman in a group of radiologists at St. Joseph's Hospital in Phoenix, where I did my residency, and I stayed on there on staff. And being the only woman, nobody wanted to do mammography in those days, and it was just really starting. So I was designated to look after the mammography side of the practice, and I quickly became very interested in it, educated myself. And I've stayed there for the last 30 years, actually.
So you've really been here since it really, this practice or this knowledge started coming to the general awareness.
Absolutely, and I've seen so many changes. I mean, our advances in diagnostic imaging of the breast has been phenomenal. But what struck me, or does strike me on a daily basis, is that the way we treat breast cancers hasn't really progressed that much since I was in medical school, right? I'm not going to tell you how long ago that was. But anyway, so I was in medical school in London, actually, before I came out here. But I was just struck that we were struggling to find smaller and smaller cancers, which sort of translate to less aggressive cancers. They tend to start off small and slower growing, most of them. And if you leave them long enough, they can become certainly life-threatening. But these small cancers are very treatable. And we were throwing the book at them, just like I learned in medical school. We were still doing lumpectomies and radiation, and mastectomies and sampling lymph nodes. And that's pretty traumatic for the whole body. And I was thrilled when IceCure walked into my office with this new probe that they'd come up with, which allowed us to do cryotherapy in the breast, because we've been doing cryotherapy of small skin cancers for years very successfully. We know we kill cancer. So they have come up with the idea of being able to do this in the breast. We've already been doing it for years in kidneys, liver, lung, prostate. I think we have to put the guys to sleep to do that. No, prostate. Yeah. Can you imagine having your prostate done with a large probe? So the women have no problem with it, by the way. Women are tough. So we're able to do cryotherapy or cryoablation of the breast under local anesthetic. So as somebody that has been, doing mammograms, a lot of breast ultrasound, we are finding these cancers smaller and smaller. The next step is a needle biopsy, pretty much everywhere now. And really cryotherapy or cryoablation is very similar to a needle biopsy. We, instead of inserting the biopsy needle through the cancer, we are inserting a probe through the cancer, which is cooled with liquid nitrogen. And we can kill that cancer in as little as 6 minutes. Larger tumors, we usually go for 8 or even 10 minutes. And then we allow that to thaw and we retreat. So women can walk out of there, in 30 to 40 minutes and may now have a dead cancer, which the body gradually resorbs over the next few months. But the reason that I'm really actually excited about this is that killing that cancer with freezing seems to stimulate the body's abscopal effect, which is the immune response to that little cancer, because the cancer cells are dead, but they're still recognizable by the body. And the inflammatory reaction that goes on around that dead cancer allows the patient's immune system to ramp up to deal with that cancer. And that's really where Dr. Rubin comes in. And I've worked with him for a long time, ever since I started doing these, because it struck me that we needed to prime the patient's immune system to make that happen as effectively as possible.
Yeah, I'm so glad to hear you say that, because that leads me right into my next question for Dr. Dan. What is naturopathic medicine and how does it differ from traditional? When I introduced this session today, I said that oftentimes people see this as a conflict. They don't understand how the two areas can work together. So maybe you could explain that to us.
Sure. Naturopathic medicine is legitimately its own system of medicine. We have our own naturopathic medical schools, which are federally accredited. The right ones are. And we still learn the same ologies, whether it be embryology, physiology, anatomy, biochemistry, because we still have the same body. But it's more in the philosophical approach and the application of medicaments and what we choose to use. For instance, in the state of Arizona, I have a DEA number. I can prescribe. I have slight limitations on what I am allowed to or what I'm not allowed to prescribe. Rightly so, I think. But it's how those would be applied to the human body, how you would seek to understand and maybe interpret the physiology. And also naturopathically, we tend to maybe order different tests, which are readily available, widely available to any physician that would want to order them. But it's really in the approach to the body. And some may say the belief system. I don't use the word belief in medicine because I think belief brings in dogmatism, and there's really no room in medicine for dogmatism. I think it's more on interest and how somebody would approach and philosophize about the body. And in naturopathic medicine here, we have a board of medicine, and we license, I think, over 900 doctors in the state of Arizona. I sit on our board of medicine, and I'm particularly interested in integrative oncology. I have been for over 2 decades, and it's really, there's a person with cancer, and conventional medicine oftentimes for somebody is not just the only answer for them. It doesn't work all the time. And so a combination can help accelerate the activity of the conventional drugs. It can help them maintain their schedule of drugs, and it can help people, ease through it. It can prepare them for it. And oftentimes, with our, functional or naturopathic testing, we can uncover certain pathways which may be relevant to a targeted therapy or a drug that may be able to use that I may or may not be able to apply. But that's where relationships come in. And being a member of the greater oncology community for the last many years, being able to understand the principles and practice of oncology and how to speak to my MD or DO colleagues or chiropractor colleagues or nurse practitioner colleagues or whoever's on the team is important to approach the single person so that people can be better with a team. And I think that's really the essence of how we integrate. And we do it from a non-threatening perspective. I mean, Dr. Barclay-White and I have seen patients or co-managed patients for years with mutual respect, and I have great admiration for what Dr. Barclay-White has done with her career, and I've watched it since I graduated. I mean, I think I first met you just after I graduated in the late 90s, and it was phenomenal. And then to be able to sit at a table in front of, where she talks and talk about the immune system, and that has risen in importance in the world of oncology is phenomenal. And some of the leading drugs, Nobel Prize winners, are for immunofunction. And that's where I got my start, is understanding that truly your first and last defense against tumors is your immune system. So development of a tumor, existence, to be able to diagnose one means there's a relative failure of the immune response to allow that tumor to develop. Cryotherapy is amazing because, like Dr. Barclay-White was saying, is that it invokes the immune response as a side benefit.
Right.
Maybe it's not a side benefit. Maybe it was intended.
Well, I don't think it was intended, because we talked about being able to kill the cancer cells for several years before we started getting really interested in that immune effect. And it just makes so much sense to me, less is more concept. Why are you throwing all this stuff at the whole body when you've got this little tiny localized slow growing cancer? And the side effect, as you say, you are doing, because it's so small, the body might not really have recognized it and might not be building up an immunity to it. But we do know that by freezing it and causing an inflammatory reaction around it, those dead cancer cells are now recognizable by the immune system, and we can mount.
It's huge. It's like they won't
Let me jump in here for a minute, docs. Let me jump in. It sounds like
technical. We're having a good time here. I'm sorry.
We're not at lunch, right?
Yeah, we're not at lunch.
it sounds like, to me, how I would describe the two of you is more of a holistic approach, meaning the whole body. You've got the medical side along with the naturopathic side, which of course involves medicine too, but you come at it at the same problem from maybe some different interests or different perspectives. And if you work together, then women and men, because men get breast cancer too, have a greater chance of being successful in fighting the cancer. And when you had talked about, Dr. White, that it triggers the immune system, basically what I'm hearing you say is that it causes the body to wake up and go, oh, wait a minute, this is really bad stuff. We need to get rid of this, or we need to start figuring out this is bad. Let's get rid of this. And it is able to do that if you have a stronger immune system to be able to allow the body to get through this. Does that sound about right?
Yes, that's a very good summary. Yes.
Okay. All right, a layman's summary, right? So let me ask, this is a question for both of you. How do we know if our cancer can be treated with this cryoablation, right? Am I saying the right? Cryoablation.
So we've been very selective and very cautious to begin with. I started doing these procedures in 2016, as I say, when IceCure came and told me there was a cryo probe for the breast. We've been very cautious because obviously we didn't want to do anything that wasn't going to work, or we would put patients, further behind as far as having a recurrence or anything like that. And, we limited it to small cancers less than 1.5 centimeters, slow growing cancers, so grade 1 or 2 cancers, not grade 3, which grow very fast. And obviously they have to be in a good location in the breast, not too close to the skin, because really the only damage we can do is cause frostbite of the skin.
Oh.
They can be close to the muscle, and the muscle is too hot. It will never get cold enough to die, for the muscle cells to die. But the skin, we can certainly cause frostbite. So it's got to be a good location. It's got to be small. It's got to be slow growing. We don't want to have any evidence of any cancer elsewhere. So the regional lymph nodes under the arm, we want to look at those with ultrasound and MRI and make sure that there's nothing else going on. So those are the ones we chose to begin with. But now, 6 years later, I think most of us performing these procedures nationally, and and people have been performing them in Europe, China, and Japan for 20, 25 years now. But now we're beginning to get much braver, and we are opening up those parameters. So no two cancers are the same. So the answer to that question is we need to look at, lots of different aspects of that cancer before we can say whether the patient is a candidate for this.
Does it matter the age of the individual at all?
Yes, because younger women tend to have more aggressive cancers, right? They have a higher percentage of high-grade cancers, particularly Black women of non-Hispanic descent. They have more high-grade or triple-negative cancers. So we're very cautious with a triple-negative cancer because we know it's nasty, and we probably do need to throw the book at it with everything we've got available traditionally. But otherwise, we are treating pretty routinely patients. The studies have been done on 55 and over, 55 years of age and older. I started on women 65 and older. We've now rounded that down. And in some women that don't want traditional therapy, I will, consider those cases, and as long as they're informed and their doctors are informed and everything, we can even go to younger age. Yes.
Now, I think based on what Scott Pierce showed us, the slides for IceCure and how the probe actually works, it seems like that's a pretty good basic explanation of what you do with the cryoablation. Dr. Dan, how do you involve yourself with this? How can you support this? Because I don't think you're the one that actually uses the probe. That's Dr. White. So how do you guys work together to help this?
It's a great question. Thank you for it. And correct, Dr. Barclay-White is the technician and the doctor, the radiologist who's using the probe. I'm not. I'm kind of the guy in the office who knows how to test the physiology and can test the immune system to see if there's a place we need to pivot or we need to support or augment. And so one is looking at not just the immune system, but the whole of the physiology, knowing that just because a woman had one cancer means that she could get another in that same or the other breast. The idea with cryotherapy is, like Dr. Barclay-White had said, is you're trying to engage the abscopal effect, which really means if you can get the immune system to recognize those now dead cancer cells, they are now armed with information, and they can go scouting in the body to go look for rogue cells, which may have escaped, or been floating in the blood or floating in the lymph or landed somewhere, which is scary to women, or that may be developing, we just weren't able to see them yet. And that's where I really come in, is because just because you did cryotherapy and just because the cold, the thaw, and the dead cells can stimulate the immune system doesn't mean that you have an immune system that was stimulated or that is active, which is why you got the cancer in the first place.
Right.
Which is why we're sitting here talking, is because there's lifestyle modifications that we can be made, but to decide which ones need to be made, we don't want to make generic ones. We'd like to figure out which ones are important for that particular person. So we interview the person, we work with them, we look at their dietary issues, we look at how they sleep, what their interpersonal relationships are, how much they laugh, how much they sleep, and what they eat. Those are important. We look at body composition. One of the ways to help stop recurrence of, especially an estrogen receptor or a hormone receptor positive breast cancer, is looking at body fat percentage of a woman. And so we do that, and then we can prescribe lifestyle modifications. We can prescribe pharmaceuticals if we need to, and we can prescribe nutritional supplements. And it sort of depends on what the person needs. Just because they have a small aggressive or non-aggressive breast cancer treatable doesn't mean that they don't have other comorbidities or other issues too, which may make them susceptible to other cancers or other issues down the line. And that's really the role of the naturopathic oncologist in the co-management for a patient going through cryotherapy.
So one of the questions we just received is, how can women stimulate their immune systems to help in this process? And it sounds like you talked about dietary considerations, maybe active lifestyles or exercise, vitamins, supplements. What are some other things that I didn't list there?
laughter. Literally,
Yes,
you know,
yes.
we were giggling before this started because I mean, laughter really does improve certain parameters like natural killer cell function. Same thing.
That's fascinating.
Yeah.
Yeah.
And it's like we're programmed to laugh, and it's good. And it's a nice expression. Hugs. Hugs stimulate the immune system. Hugs do a lot physiologically. Here we are, middle of 2021, and there's far less hugging going on.
Yes.
Yeah.
With our family even, and there
Yes.
has been.
Yeah.
And so I mean, literally sometimes the little things mean a lot. But we don't test that. It's not like I'm going to do a pre and a post hug immune system stimulation test. But we know this, and we know what the physiology is. We know what the physiology is of a tear from laughing versus a sorrowful tear. Nature bathing. There's far less nature bathing, especially in the summer in Arizona for Arizonians, Phoenicians. But getting out in nature and getting out of a 2D world, which we're stuck
Yeah.
in so often,
Yeah.
and seeing the 3D world out there, it's what our brain needs. These things have great physiological effect, as does sleeping. And so those are simple things of how to treat. I like to say the human frame, physiology, and psyche. And if you're nature bathing, you're changing your physiology because you're hiking. You're doing something good for your frame because you're hiking. And for your psyche, I mean, it's different biochemistry and what you see in the vastness, whether you're in a forest or in the desert or in the ocean or what have you, but it's different than a pool, and it's certainly different than a screen. Those are the simple things that don't necessarily cost, and it's not medical where you take a supplement and say,
Right.
like, 1,000 milligrams of vitamin C before bed, or,
Hugs in a bottle.
So, sorry, yeah, go ahead.
I'm going to use that hugging part on my soon-to-be teenager, right? He doesn't want to hug his
Simpatico.
mom. So let me get back to the cryoablation. Is the cryotherapy just as effective as a lumpectomy or in radiation or a mastectomy?
So we look at the way we tell that, for the first 100 cases, they actually cut out, after the cryotherapy, they cut out the tumor. I think they did it probably too early, but they cut it out at 3 months to prove that there was no viable cancer there. That was in the first 100 cases. They didn't find any, basically. So the next 100 cases on the next trial, they didn't insist on having a lumpectomy. So then we moved to, okay, now we've got to follow this cancer just like we would normally for 5 years, because most cancers will recur. If they're going to recur, the most common reoccurrence is the first 2 years. But certainly by 5 years, if you have another cancer in the area, you don't consider that's the same cancer. So if you could get the patient to 5 years without a recurrent cancer, then it is as good as lumpectomy and radiation or mastectomy. And most of the cancers that I would be treating, the alternative would be lumpectomy and radiation. And the radiation is really performed to stimulate the immune system.
Yeah.
Because if you cut out all the cancer cells, the body's actually got nothing there to find, right? So it's that inflammatory reaction that occurs around the dead cancer that actually stimulates the immune system. And we do know that the immune stimulation is better after cryo than it is after radiation, which is interesting.
Which has different biochemistry associated with it, because there's a lot of inflammation from the radiation beam.
Yes.
I often tell patients, hey, you're going to expose this cancer cell to the immune system, but the sheer radiation, which can be toxic to the body, but it's a necessary toxin, so to speak, can put up like a biochemical wall, and the immune system sometimes can't get through. And so
Exactly.
when patients are going through radiation, I seek to change that physiology, promote the effect of the radiation, obviously, but improve, help facilitate the immune response.
Right. And, we used to pretty routinely, and still in some places they do, irradiate the whole breast for a 1 centimeter or less tumor. And that to me was just overkill. And under those circumstances, you're stressing the body unnecessarily, I think. Right?
It's a lot of stress.
So that brings up a good point. You talked about what you look at to see which cancers can be treated. Is there ever too much breast cancer or too big of a lump, or just too much to be able to treat with the cryoablation?
So we're limited somewhat by the size of the balloon we cause around the cancer, because we want to kill the cancer and we want to kill, a centimeter of tissue around the cancer, which is what incites the inflammatory response, right? So we're limited somewhat by the size of the balloon. And that's why we say, let's do cancers less than 1.5 centimeters, because we know we're going to get a zone of kill all the way around it. But bigger tumors also benefit. We do know that doing a cryotherapy on a bigger tumor and not necessarily removing all of the cancer does have an effect on the immune system. It sort of ramps it up. So bigger cancers, some people in the country are doing multiple probes through them to kill the whole cancer at the same time. And other people are not doing that yet. But this is very early science in the treatment of breast cancer. And I think as our results come back, so impressively, that we will get braver and braver with bigger cancers. The big one is a young woman with a high-grade or fast-growing tumor. We're really worried about those. And I encourage all of my patients to see a surgeon anyway to understand their alternative, options. I encourage them to see Dan, because I really think no matter what they decide, they should be seeing somebody like Dan to make sure that, we're priming the immune system as best as we can to kill this cancer, but also future cancers, because that organism, is susceptible to breast cancer. They got the first one, and they have an increased chance of getting a second one down the road.
Okay. So what are some side effects of the cryoablation, if there is any, and about how long does your typical, if there is ever really a typical, or I should say an average treatment?
So it's a one session. The treatment is, probably an hour of room time. And during that time, we're positioning the probe, which is obviously very important. It's easier in a bigger cancer, a little bit more of a challenge in a small cancer, because you have to go straight through the cancer, because you don't want the ice ball to grow and move the cancer out of the way. So that takes some time, but the actual freeze protocol is I would say on average 8 minutes, and then a thaw for 8 minutes, and then a second freeze for 8 minutes. And most cancers are taken care of with that one treatment.
Wow. What about side effects? And Dr. Dan, do they come back to you to help manage any side effects or results from the cryoablation?
So really the only side effect is frostbite to the skin. And out of the cases I've done, we have had 2 ladies that got a small area of frostbite. Because the cancer was very close to the skin. And we knew that going into the procedure, and we knew that we might compromise the skin. But we have methods of floating the skin off the cancer. So most of the time that doesn't happen. That's actually quite rare. So frostbite is really the only downside. We don't cause bleeding because we freeze the little blood vessels, as a side effect as we blow up the balloon. There's really no pain. There's no scarring. They leave the procedure with a big cold ice ball in their breast, but that obviously melts over the next 24 hours. And then that lump they can feel, which will be bigger than the cancer because we've created a zone around it, will gradually fade. And most women can't feel anything at 2 years. And of course, you've got no scars or sutures or indentations or anything like that.
So after the cryoablation is done, Dr. Dan, what do they come to you for?
So they're going to come to me for like what we had talked about before, some of the, well, actually, hang on. So they'll actually, Dr. Barclay-White, in some cases refers the patient to me before the cryo.
I like them to see you before, yes.
Before, so we can actually start some of the
Build up.
immunotherapy and build up, you bet, and just kind of take a look at them, and maybe we can help them heal more quickly, or promote the immune response, kind of start doing it so that right after the cryotherapy procedure, that night they're having an engagement of the immune response. And then really all the stuff to help prevent. And I like to see a woman beforehand, because then you get to see what they're like when the tumor is indwelling and there, and see if they have aberrated physiology. And afterwards, it's like, okay, you're pretty much the same, but you've had something done to your body, and the body isn't responding to a tumor because now it's responding to a dead tumor. And so there's a difference. And so from a prevention of recurrence or a prevention of a new cancer, you want to kind of see what they look like physiologically before the treatment. And so either way, we can do it either way. Yeah, and so we would assess them and then create a treatment plan for them.
Yes, and Dan, you do a lot of that. Obviously, you treat them in your office, but you also you will do phone consultations beforehand and after. So because some patients are from out of state.
Yeah, you do treat a lot of patients from out of state. Yeah, absolutely. We could do, video conferencing or phone apps. Thank you.
Yeah, that's a great point. You just mentioned out of state. And I know that when I was reading both of your bios, it talks about you've seen patients from many other states. How widespread is this cryoablation for breast cancer, if it is widespread?
So the problem is that because we're still awaiting on the trials, the FDA has not given complete approval. It's cleared for breast cancer. We're in the trial situation. And until the trials are completed, the FDA won't grant full approval, which means the insurance companies will not cover it until we've got full approval. Once we have full approval, we will be doing it ubiquitously. Do I dare say that word? Because it's such a great alternative to a lumpectomy, a general anesthetic, the chances of infection, scarring. Nobody wants to be in the hospital. We've actually seen more patients sort of research and become very interested in this during COVID, because a lot of our breast cancer patients, the surgery was put off. And, we're doing other things to help them control anti-hormone treatments, et cetera, but it's tough to live with a cancer that is in there. People want to get rid of it, right? So
they want to be able to laugh and hug and not have to worry about this, right?
Yeah, absolutely.
You mentioned that it's not covered by insurance yet. It seems like once it's approved, it's a no-brainer because the risks that are involved are so much less. And you would hope that insurance companies could figure that out, although don't get me started on insurance companies, right?
Yeah, me too. So there are, and that's the issue. Until the insurance companies agree to cover it, it's really difficult to say that it's going to become available everywhere. And the few of us that are scattered around the country doing it, we all feel really passionate about this and how much of an improvement it is for some women over what is available. But we're working to keep this going, complete the trials, and get the insurance company, because it's going to be so much cheaper than lumpectomy and anesthesia and radiation and right. Most cancers wouldn't need chemo, conventional chemotherapy anyway, because they're small. But it's going to be good for the insurance companies. It's going to be great for the patients. I would much rather have a local anesthetic and walk out of there than go into a hospital. And,
I'd much rather risk a little bit of frostbite than go through the alternative, right?
Yes, and it doesn't occur that often that most patients, but actually I've had a lot of patients, when I told them this is so close to the skin, I can't avoid frostbite, most of them will say, I'll take the chance.
Yeah.
And it usually works out fine.
Yep.
The lady that we did have a frostbite on, I'd actually done 2 cancers in the same area of her breast. They were 2 different cancers, I think 3 years apart, but I was creating this big balloon in the same site, and the skin, just didn't want to take it. It's like sort of doing a lumpectomy after radiation, right? It doesn't heal as well.
Well, and one of the things too, if you don't mind, is that with surgery, you're going to get general anesthesia, which has an immunosuppressive effect, and you've plucked out the tumor, and there's just nothing there for the immune cells to go back to.
Yeah.
Really, general anesthesia is an immunosuppressant?
It can have an it can have an immunosuppressive effect. It can have several, deleterious effects on people, especially if they don't recover well from the general anesthesia, depending on how long they're under and if there's complications or the duration of the surgery. So yeah, we've seen that.
So
Is there a way?
several patients actually end up having this procedure because their surgeons don't want them to undergo general anesthesia and a surgery. So, that this is an alternative for women that can't be put to sleep, and that's not uncommon, because particularly in older women.
Yeah. So is there any way you could give us a price range? Are we looking at, $100,000? Are we looking at 20,000? Are we looking at 500,000? And I know we can't pin you down, just some kind of range, so that if anybody's watching this and this is something that they really want, they might be able to understand, oh, this is a possibility. Let's go talk to her. Let's go talk to Dr. Dan and see what else, what the possibilities are.
So from our point of view, we obviously aren't allowed to discuss prices of other docs around the country, because that will be price fixing, right?
Right.
But I would say we're generally in the range of 6,000 to around 10,000.
Okay.
Yeah.
All right.
Of course, then you don't need radiation, which is a much bigger expense actually than the lumpectomy. So, there are some advantages. Yeah.
That is way less than I thought you were going to tell me.
Yes.
Way
yes.
less. So,
and hopefully Scott's going to bring down the price of the probes, by the way. So, because the probes are obviously one use, you can't use them more than once. So if he's still on, it's a plug to bring down the price of the probes.
I have a couple questions here. I don't really know what I'm asking, but can you explain more about what level of abscopal effect have you observed in the breast, and what does this mean for treatment and planning?
That's one for Dan.
Yeah, it's a hard one to answer. The abscopal effect isn't really just a local phenomenon in the breast, rather a systemic phenomenon.
What is it?
Yeah, the abscopal effect is if you can get immune recognition in one area of the body, those cells can then go survey the rest of the body by floating in the blood or the lymphatic tissues and exert the immunologic effect distantly from the initial area of stimulation. Meaning, if you can do something in one place, you can do something in the rest of the body. That's generally the abscopal effect. So the idea is to get the immune recognition of the now dead cryoablated cancer cells, get the immune system to huddle, get stimulated, plan, and then go blast itself out and survey the rest of the body and hunt for rogue cells.
That sounds wonderful.
And there is good evidence that if you treat either by removing the index cancer in the breast, if you remove it, there's very good evidence of lymph node, for instance, that was positive shrinking, and maybe in some patients they've got liver involvement, and that shrinks just by removing and killing that main cancer. And that comes into it too.
Conventional medicine is looking at the abscopal response, and there's at least 1 or 2 clinical trials now looking at using certain immunotherapies along with cryoablation to engage that response using pharmaceuticals. And so it's like, I feel like the time of the immune system is here.
Yes.
And there's been pharmaceutical development and device development to be able to engage that and really honor that true innate physiology of our body. It's really an exciting time, I think, for integrative medicine. I've been really waiting for this time. I have.
Yes, absolutely.
Well, you mentioned the immune system. COVID has had such a huge impact on our daily lives over the past year that I think the immune system is at the forefront of people's minds when they talk about just vitamins. So I think you're right when you talk about how, the immune system and
immunology. Yeah.
Thank you. It's having its time right now, like you mentioned. I have another question. As a breast cancer survivor with BRCA2 and triple negative, would this procedure have been an option for me? I think did I say that right? The BRCA2?
Yes. So I suspect the asker of this question may have been younger, and because younger women tend to get triple negative cancers, and they are linked to the BRCA1 or 2 gene. So she would not have been the ideal candidate, no. Again, sort of also we have to take into account the size of the tumor. You know, I have treated some 6 millimeter triple negative cancers in women, in younger women, but I do it in trepidation, and I really want them to have coverage with their, you know, MDs and certainly Dan because they need to know that I don't have follow-up data on that. We don't have 5-year data in this country on that. So, yes. So I right off, I would say you probably would not have been a candidate for cryotherapy.
So what is the efficacy for different stages of breast cancer? Is this being used as a primary method for DCIS?
So as of yet, we're not at the trials because they wanted to pick the perfect cancer. They wanted to prove that it was as good as lumpectomy. They actually didn't even want to exclude radiation. They just wanted to say it's as good as lumpectomy. And they insisted on whole breast radiation. That was the original trial. So DCIS is difficult because you can't often see it on ultrasound. So it's more difficult to target. You can target it very well on MRI, and we're not yet doing this under MRI, but that's really because the probes aren't able to go into the MRI suite right now, but that will come soon, I'm sure. But there are some of us that are doing tumors. So we wanted invasive ductal cancers with less than 25% DCIS. That was the ideal patient over age 55, right? A lot of patients did refuse whole breast radiation, and I ended up, and people like me across the country ended up treating them, and they didn't have radiation. So we've now got that data coming up to 5, even 6 years. We are beginning to get braver with pure DCIS. If we can see it, and we've got an MRI that says, yes, it's only this big and it's only 1 centimeter around this little clip that we can definitely see with ultrasound, then we are beginning to look at DCIS. And I think there's a new trial starting on DCIS, yes.
Will you go with stage 1 and 2 cancers?
So stage means it's into the lymph nodes, right? Typically, I'm not doing that. I'm doing stage 1 cancers or stage 0. So DCIS on its own would be actually stage 0 cancer. Yeah.
So you mentioned other countries have been doing this for a little while. Did I hear that right? And why are we so far behind?
Well, we have an FDA approval process here that tends to put us further behind. This started actually, a Japanese surgeon started doing this, and I think he's been doing it for over 20 years now with great success. He never published his data, probably because he was so busy doing them. And we've encouraged him now to publish his data. The European and the Chinese have started doing them big time, but we're not seeing data out of China yet. And then Europe is now starting to do them, but I haven't seen any European data yet. We still seem to have the most data in this country, and it's really early. I mean, we've only been really looking at it for the last 5 to 10 years. Yeah, we haven't got 10-year data yet.
So we're coming to a close. We're almost out of time here, but Dr. Dan, you've given us a lot to think about, and how you've explained how important it is to look at this aspect, your aspect, when it comes to treating breast cancer. What do you want to say to people watching out here that you haven't already told them, or that you think is so important for us to take away from this?
I think perhaps I've insinuated, but maybe not said it as clearly, is that I think really the time is now to take care of that human frame, your physical body. We have one. There's a lot of things that we're bombarded with during the day and even night that cause that, damage to that frame.
Yes.
And the physiology, we're probably in the heyday of toxicity on a day-to-day basis, whether it be through Wi-Fi or just common chemicals in our water system, or that find its way into our food or our air. I mean, there's just more and more of this industrialness.
Mhm.
And the psyche, I'd say the world has had a toll taken on its psyche. And those are really the things that I talk about, are the frame, the physiology, and the psyche. And that's really a way of saying body, mind, spirit.
Yeah.
And we need to have accountability for ourselves, because cancer is serious and it encumbers you in many ways if you're diagnosed or if it advances. And that would be my take-home message, is to, a lot of us know what we need to do to stay healthy, and a lot of us just don't do it for
Yeah.
whatever reason, and I won't get into that, obviously, but thank you for allowing me to say that.
So if people want to talk to you, Dr. Dan, they can find you at Naturopathic Specialists, LLC in Scottsdale. Do you have a website?
Yes, our URL is listenandcare.com, because we listen and care, and it's all written out, it's all one word, listenandcare.com.
And so go to listenandcare.com for more information on Dr. Dan, and do some more laughing and hugging, because I'm definitely going to tell my soon-to-be teenager about that. Dr. White, the same question to you. We've talked a lot about cryoablation, breast cancer, how the two of you work together. What would be the takeaway here that you would want us, if we could only take one?
Well, the best way is to prevent it, right? And I feel the same way as Dan. Taking care of yourself is so important. Don't get to the point where you even have to consider cryo, right?
Mm-hmm.
And we do know that it's got significantly worse. I mean, in 1975, it was 1 in 11 women would be diagnosed with breast cancer in this country. It's now 1 in 8. And I completely believe that the environment that we live in is just toxic. And encouraging our children, along those lines, I think is so important, because potentially it can get worse than that. So take care of yourself, first of all, and don't even get there. And then if you are unlucky enough to be, well, I should say, if you're lucky enough to be diagnosed with a little tiny cancer, which we are finding with screening, whether you're screening with mammography, ultrasound, MRI, there are some centers that actually do very good thermography. I don't interpret thermography or anything like that, but there are some things that aren't just 3D mammography, which is being very pushed right now, right?
Mm-hmm.
I think ultrasound is an excellent thing to do, and feel your breast tissue. If you're a young woman, don't get to know what your breast feels like on a monthly basis, because young women find their breast cancers because we're not screening young women yet.
Yeah. All right, so Dr. White, where can people find you?
So my website is Breast Cancer Cryo, all one word, .com.
Okay, all right. Fantastic. Thank you, both of you, for this wonderful information. It's very enlightening and it's very positive. And we need as much positivity as possible in this world of toxicity, right? That's what you said.
Absolutely. Absolutely. Yeah.
So, and I also want to say thank you again to Scott Pierce. He is the U.S. Commercial Director of IceCure Medical, Inc. That's the company that creates and manufactures and sells those probes that Dr. White uses for this cryoablation. So thank you, Scott, for being part of this and sponsoring this She Talks. We greatly appreciate it. And I also, of course, want to give a big shout out to Rosenden and Pure Insurance, our She partners over here at Arizona Foundation for Women. And for any of you watching that would like to have some more interaction with AFW, go ahead and go to AZF, wait a minute, now I can't say it, azfw.org, and look and see how you can become part of this organization. You can be a member, you can be a She Partner, you can be part of our She Talks, you can be part of our She Leads. We'd love to have you, and give us your email address. We can give you updates on what's going on and incredible information like what Dr. White and Dr. Rubin had just shared with us today. So thank you all for joining us today. And once again, thank you, doctors, and thank you, Mr. Pierce. And we hope that you enjoyed this. Reach out to the doctors if you have any other questions. And if you can't find them, please email us over here at AFW and we will give you their information. So have a wonderful day, everybody, and thank you for joining us.
Thank you.
Thank you.